All right, we're going to get started. We have a lot to get through today, so we don't want to keep you here too late on a Friday afternoon. So I'm Amanda Liszewski, this is Surabhi Palkimas, and today we're going to spend about the next hour or so talking about thrombocytopenia. So our plan for today is to start by going through and reviewing some of the pathophysiology and the clinical findings associated with both heparin-induced thrombocytopenia and also a couple non-drug causes of thrombocytopenia. And then we're going to get into the literature and summarize some of the recommendations that are out there for both current and emerging treatment strategies for thrombocytopenia associated with these various conditions. So we'd like to first start off with a patient case. And as you'll see, this patient case tells a story that's probably very similar to the stories of patients that you all see every single day. So hopefully this will be a good case to work through, and we'll keep coming back to him throughout the rest of the presentation. So our patient CW is a 52-year-old male with history of a gastric adenocarcinoma, status post-total gastrectomy and adjuvant chemo. He was admitted to UVA initially for malnutrition on July 26 of this past year and found to have a large bowel obstruction. After a couple days of workup, he underwent an exploratory laparotomy to address this large bowel obstruction and was admitted to the SICU postoperatively. After a couple days recovering in the SICU, this patient started to clinically decompensate, had a newly developed septic episode, was found to have fecal peritonitis, which required another exploratory laparotomy and initiation of antibiotics for this new episode of sepsis. A couple days later, he required another trip to the operating room for a washout for continued ongoing source control of this new infection. And it was around this time, on August 3rd, that the SICU team also noticed that his platelet count had been trending down throughout admission. So they astutely reviewed his medication list and saw that he'd been receiving enoxaparin since the time he was admitted. And so, of course, they became concerned for heparin-induced thrombocytopenia and reached out to our hematology colleagues for guidance. Now, thrombocytopenia is something that happens quite frequently in our hospitalized patients. The reported ranges of thrombocytopenia can vary pretty widely based on the references that you look at, but data shows that up to almost 70% of patients can present to an ICU with thrombocytopenia, and another up to 44% of patients can develop thrombocytopenia during an ICU stay. This isn't a problem that's just limited to ICU patients, however. Another study observed that up to 1% of all adult inpatients in an acute care hospital had thrombocytopenia. So it's something that we're all going to have to see and manage every single day. Now, the first step in managing patients with thrombocytopenia is, of course, figuring out what's causing it. But as you'll see, a lot of times this is easier said than done. So in our patient, is it heparin-induced thrombocytopenia that's causing his platelet decline, or might there be some other things going on here? Now, in terms of figuring out what's causing thrombocytopenia, I know that that is step one in figuring out how we're going to manage it. But as you can see with the list of potential causes of thrombocytopenia, this can be quite a daunting task. So generally speaking, there are four main mechanisms of thrombocytopenia, how it can happen. We can have hemodilution, which occurs with infusion of fluids or blood products. We can have increased platelet sequestration. We can have increased consumption or destruction of platelets, or we can have decreased production of platelets. Now, of course, we wouldn't have time to go through every single one of these, even if we had all day, so we're only going to focus on a couple today that are most relevant for the patients that we're all going to see here at UVA. And we're going to start with every pharmacist's favorite, drug-induced thrombocytopenia. So drug-induced thrombocytopenia is typically the result of antibody-mediated platelet destruction, with these antibodies getting induced by the drug in question. Rarely there's some other mechanisms that can be at play here as well, like bone marrow suppression and other immune-mediated mechanisms, but these are less common overall. So what are some drugs that you all see in your patients that commonly get blamed for thrombocytopenia? Anybody? Yeah, Peptid is a big one. Yeah, there's a whole number of them. So various antibiotics, anti-epileptics, things like H2 blockers. But for purposes of today's presentation, we're really going to focus here on heparin. So now I'll turn it over to Surabhi to talk a little bit more about heparin-induced thrombocytopenia.
So heparin-induced thrombocytopenia is a dangerous immune-mediated adverse drug reaction to unfractionated heparin, but less commonly seen with low molecular weight heparin. Unlike other forms of thrombocytopenia where patients are at risk for bleeding, with HIT, patients are not at risk for bleeding, but they're more at risk for venous or arterial thrombosis. This is why sometimes HIT is termed heparin-induced thrombocytopenia thrombosis. It occurs in about 0.2 to 5% of patients, heparin-treated patients, with 1 to 3% incidence in patients with cardiac surgery. Thromboembolic complications develop in 50% of patients with confirmed HIT. Mortality associated with HIT is reported to be about 20 to 30%. There's two different forms of HIT that can develop in a patient. Type 1, also known as heparin-associated thrombosis. Type 2, also known as heparin-induced thrombocytopenia. Type 1 is non-immunologic response to heparin therapy. It occurs in about 10 to 30% of patients, whereas type 2 is the immune-mediated, potentially fatal disorder known as HIT. It occurs in about 1 to 3% of patients. In type 1, the mild thrombocytopenia occurs in the first 2 days after heparin administration and usually returns back to normal within few days. This usually occurs in patients with other medication causes of thrombocytopenia or patients that are usually septic. This type of HIT is not associated with thrombosis, whereas type 2, which occurs, the thrombocytopenia occurs between 5 to 10 days, but this one is associated with thrombosis. When looking at thrombocytopenia of HIT, heparin exposure leads to sometimes heparin exposure leads to IgG antibodies. IgG antibodies then recognize the PF4 heparin complex and will bind to the FC receptor on the platelets. This leads to platelet activation, and then the end result is thrombosis, which leads to venous or arterial thrombosis. And this is usually the type of HIT that we see in our patients where thrombosis is developed. What types of patients develop HIT? There's heparin-related risk factors. Duration of heparin therapy plays a huge role, so anybody who's getting heparin for more than 5 days are at risk for developing HIT. The type and dose of heparin matters too, so anybody who's getting unfractionated heparin is more likely to develop HIT than patients who have low molecular weight heparin on board. Bovine unfractionated heparin is associated with developing HIT more than porcine unfractionated heparin. Therapeutic doses of unfractionated heparin are greater risk of developing platelet reduction than low molecular weight heparin. Indication of use is important, so anybody who's our surgical trauma patients, they're at more likely risk of developing HIT than our medical patients. Patients that are over 40 years of age and female sex are more at risk for developing HIT. So with heparin-induced thrombocytopenia, the major patient characteristic is thrombocytopenia, which is 50% drop of platelets from baseline. But HIT presents in different patterns. So there's a rapid onset of HIT, which occurs within hours or days of heparin exposure. Usually these patients have received heparin previously in the last 100 days. And then there's a typical onset of heparin-induced thrombocytopenia, which occurs within 5 to 10 days of heparin exposure, and that's mostly the types of patients we see here. There's also another form of onset pattern of HIT, which is the delayed, which usually occurs between 9 or 40 days or more of heparin exposure. In this type of heparin pattern of heparin-induced thrombocytopenia, sometimes platelet drop will happen even after heparin has been DC'd. Another type of thrombocytopenia that's really important is patients who have had cardiac bypass surgery. In these type of patients, you'll see a bimodal response where thrombocytopenia will happen at day 1 or 2, but the platelet count will continuously rise. The concern in these patients we have is if the platelet drop begins after 4 days and continues to drop after 4 days, this is when we start to think about HIT. Some of the complications of heparin-induced thrombocytopenia, the most common is venous thrombosis, as I mentioned earlier. 7 to 55% of untreated patients who present with thrombocytopenia develop DVT or PE. We also see arterial thrombosis, which happens about 3 to 10% of the patients, and majority of the cardiac bypass patients see arterial thrombosis instead of venous thrombosis. Some of the less common complications of HIT are limb gangrene. We'll also see heparin-induced skin necrosis. We also see systemic reactions, which happens within 30 minutes of IV heparin exposure. You'll see fever, chills, hypotension, tachycardia in these patients, so this is when we start to suspect HIT. In order to make the diagnosis of HIT, we have to really consider the clinical scores and the testing that we do for HIT. So in order to do a clinical score, we have a 4T score that has been developed, that has been studied extensively, in which we look at degree of thrombocytopenia, timing of thrombocytopenia, and if thrombosis is present or not. One of the other things of the 4T score is other causes of thrombocytopenia. This is where we have a huge opportunity to play a role. Oftentimes when we get consulted on heme, we see that this part wasn't really looked into very well. So we really need to think about what other drugs put a patient at risk for thrombocytopenia, what other procedures, what other renal replacement therapy patients going through that could put them at risk for thrombocytopenia. So we could really help and contribute our colleagues by paying a little bit more attention to the other causes of thrombocytopenia. Patients with a score greater than 4 are considered either in a category of intermediate probability or high probability. These patients, when they have a 4T score calculated, they have a poor positive predictive value, which is why we send HIT testing for these patients. Patients with a low probability score will have a score of between 0 and 3. They usually, if the score is calculated accurately, have a high negative predictive value. Another score that I came across in literature is conducted for patients with cardiac bypass patients in whom we may not want to think about the 4T score, but may actually want to consider this score. This score is actually just looking at the pattern of platelets, because I mentioned earlier there's a bimodal platelet decline in patients with cardiac bypass surgery. So we can think about just the platelet pattern in these patients and also think about the timing of cardiac bypass to help determine a score. In these patients, the score of greater than 2 is considered high probability, and patients with less than 2 points is considered low probability. So we could consider sending HIT testing if the probability is greater than 2, but if it's low, then we wouldn't do it. So we can apply a different score for our cardiac bypass patients. The other type of thing that we do for HIT diagnosis is laboratory testings. There are 2 different types of laboratory testing that we look at, the immunologic and functional assays. The immunologic assays, we do an ELISA, which is 99% sensitive and have a high negative predictive value. So it helps us rule out HIT in patients. But it has a low specificity, so there's oftentimes a false positive results that we will see. This test is really detecting IgA and IgM and IgG, so it's really hard to have a good specificity with this test. In order to make this test a little bit more specific, what we can do to our assays is just test for IgG only and also display an optical density. The functional assays that we do for HIT testing is the serotonin release assay, which is what we have available here at UVA. And it's considered a gold standard because it goes through several mechanisms of testing, such as radioactivity, to determine the percentage of serotonin released from the platelets. So this is the test we go for. The other test that is available, it tests for platelet aggregation, but very few institutions have this in place, so we don't have, and most institutions don't look for this because it's very hard to get on board. This is a snapshot of a HIT test result that came back on our patient. What I want to show you is that since last year, we changed our HIT testing where we now display optical density for all the platelet antibody testing that we do for our patients. On the bottom where you see the optical density, what we do is anybody who has an optical density greater than 0.3, we automatically send an SRA. We did this improvement in our HIT testing to increase the turnaround time that we have for our HIT testing and also to increase our specificity of the testing. And also our platelet antibody testing only detects IgG. So now our test is very good where it has a very higher sensitivity and specificity compared to what we did in the previous years when we were sending it to Mayo Clinic. Now we send our testing only to Chantilly, Virginia at the Quest Labs, so we are able to see a faster turnaround time. Also, even though SRAs are already very specific, I just wanted to share with you that the specificity of our SRA that comes back has about 89 to 100%. So we can, when we get a negative platelet antibody testing for our patient, we can rule out HIT and start heparin on those patients again. So this brings us to our first assessment question. Heparin-induced thrombocytopenia is an immune-mediated condition which not only induces bleeding but also results in thrombotic state, prothrombotic state. True or false? false. We don't usually see bleeding with our patients with HIT. We only see thrombosis.
All right, so now coming back to our patient CW, where we left off, we were left with the question, does this patient have HIT? So we calculate a 4T score for our patient, and we find that the 4T score comes out to be 3, indicating that this patient has a low probability of actually having HIT. In the meantime, though, the SICU team had already discontinued this patient's enoxaparin and sent off for the HIT antibodies, so we've kind of committed ourselves to the HIT workup at this point. So now what we can be doing is thinking, what are some other reasons why this patient might be thrombocytopenic? So now we go back to our laundry list of potential causes of thrombocytopenia, and of course as pharmacists, drugs are always the first thing that we should be thinking of, but at the same time, there's a whole heck of a lot of non-drug causes of thrombocytopenia that are also on this list that we need to be considering. So I think as pharmacists, we have a responsibility within our teams to not only consider drug causes as a potential cause of thrombocytopenia, but to also bring up some of these non-drug causes and to steer our teams away from potential drug causes of thrombocytopenia whenever they're really less likely in the grand scheme of things. Now, in terms of working up patients for HIT and evaluating our patients for HIT, we know that the literature supports that HIT is largely overtested for. This retrospective study from the Cleveland Clinic a few years ago sought to look at HIT screening practices in 63 consecutive patients in whom HIT was suspected. And overall, what they found was that only 5 of these patients, or about 8% or so, were actually diagnosed with HIT. Notably, almost half of the patients, quite a large percentage of them, had a low pretest probability with a 4T score of between 0 and 3. So the authors concluded that overtesting for HIT is highly prevalent in the tertiary care setting. It ends up leading to increased cost of treatment, potentially leading to increased length of stay, and exposes our patient to risks of non-heparin anticoagulation when they otherwise wouldn't require any of the kind of anticoagulation. Now, in addition to overtesting our patients for HIT, we also know that we are overtreating our patients for HIT. So a prospective study published just recently actually looked at the appropriateness of anticoagulation changes that were made in a SICU patient population due to a suspicion of HIT. Once again, they found that HIT was largely overtested for, with only about 7% of these patients in whom HIT was suspected actually being diagnosed with the condition. But more importantly, while all 10 of the HIT-positive patients had appropriate changes made to their anticoagulation, additionally, about twice as many patients, almost 20 patients, received unnecessary non-heparin anticoagulation. And in at least one of these cases, this anticoagulation change was implicated in a patient's death. So it's definitely not a benign intervention to be changing anticoagulation and working up these patients for this condition, especially when there's a very low likelihood of it existing based on our screening tool, the 4T score. So like I said, we do have the 4T score that we can use as a screening tool and figure out who we need to pursue further testing on, but at the same time we know that it is not always perfect and that we need more stringent criteria to determine who actually needs a full workup for HIT. So in the meantime, while we're developing these criteria, what we can do as pharmacists is educate ourselves on some of the non-drug causes of thrombocytopenia, so again we can help steer our teams away from that idea whenever it's really less likely. So today I just wanted to touch on a couple non-drug causes of thrombocytopenia that we're going to see very commonly in our patients here at UVA. And the first one of these is going to be sepsis. Now we know that platelet decline is something that happens very frequently in our septic patients. There are studies that cite up to 70% of patients with sepsis are going to experience a platelet count less than 150,000. Platelet count typically starts falling within 3 to 5 days of developing a new septic episode and ends up normalizing in about 3 to 7 days once we start gaining control of that underlying condition. We also know that development of thrombocytopenia during a septic episode is associated with increased morbidity and mortality, and that's why platelet count is included in a number of our severity of illness scoring systems. This is also supported in the literature as well. As we can see that it's much more common for non-survivors of a septic episode to experience thrombocytopenia when compared to those that do survive sepsis. Now, why does this happen? Why do patients with sepsis develop thrombocytopenia? I wish I had a really straightforward answer, but there's actually a number of different mechanisms at play here. So first we have an element of decreased platelet production. So even though platelets don't have a nucleus and don't divide like many of our other cells do, A large experimental study in 2010 showed that platelets are actually capable of generating new platelet cell bodies, but that this process is also inhibited by the presence of E. coli. So we actually do have an element of decreased production of platelets in patients with sepsis. Platelet receptors also play a role. So we know that bacteriolipopolysaccharide, or LPS, is capable of activating platelets. And these activated platelets increase expression of various receptors, things like toll-like receptors and adhesion molecules. And these increased receptors lead to ongoing platelet activation. So it really creates this vicious cycle of platelet activation that leads to thrombocytopenia. There's also an immune-mediated component to this as well. It's been shown that both ICU patients and septic patients are shown to develop antiplatelet autoantibodies, and these autoantibodies can go on to destroy platelets, so we have an element of platelet destruction as well. We also have platelet sequestration. Excuse me. Experimental studies show that platelets can become sequestered, both at the level of the endothelium and within the liver, with all the inflammatory processes that are going on in sepsis. And these sequestered platelets can then become either permanently activated, destroyed, or just remain sequestered and otherwise pulled out of the circulation. And lastly, and maybe most importantly, we have an element of a consumptive coagulopathy that's going on in sepsis. We know that there's widespread platelet activation. We know that there's also dysregulation of our coagulation system that happens in sepsis. And therefore, platelets will become consumed into the formation of fibrin clots and can also become consumed into aggregates with white blood cells, again in response to all of the inflammation that's going on. So when it comes to diagnosing sepsis-associated thrombocytopenia, unfortunately, we don't have any one single laboratory marker that can confirm a diagnosis. I think we just have to recognize that sepsis is one of the most common causes of platelet decline. So if we do have a septic patient with a platelet count that is declining, it's very likely that our thrombocytopenia is due to the septic episode. But at the same time, I think it's important to rule out other causes, do our due diligence, and recognize that there might be multiple reasons for somebody to be thrombocytopenic. So I think we need to really consider sepsis-associated thrombocytopenia just in the context of everything else going on with the patient. So for example, if there is a concern for HIT, and we have already started this HIT workup, we need to consider sepsis as a possible other cause for thrombocytopenia in our 4T score and assign the patient a 0 for that criteria. So now switching gears a little bit, the other type of non-drug thrombocytopenia that I wanted to just touch on quickly was disseminated intravascular coagulation, DIC. Now, personally, DIC is, I feel like, a term that I've heard thrown around a whole lot, but I never really had a good understanding of exactly what DIC actually was. So the International Society on Thrombosis and Hemostasis defines DIC as an acquired syndrome that's characterized by the intravascular activation of coagulation that happens without a specific localization and that arises from different causes. And we'll talk about what that means a little bit more in a second. DIC is something that's also fairly common that we're all going to come across at one point or another in patients either in the ICUs or on the acute care floors, and estimated to be present in as many as 1% of hospitalized patients. It's associated with quite a large number of different clinical conditions and disease states, and generally it's going to be associated with these disease states that involve systemic inflammation, so like the ones I have listed in the table below. Now, similar to our sepsis-associated thrombocytopenia, we also know that DIC is shown to be an independent predictor of organ failure and mortality in these patients, and again, that's supported with the literature. Now, as far as how the patients with DIC are going to present, DIC is typically characterized by widespread microvascular thrombi. So thrombi in DIC can actually form in any size vessels, but when they form in the microvasculature, they can compromise blood supply to any of our various major organs and ultimately leading to failure of those organs. And what makes DIC a little bit confusing is that at the same time, while we have all of this ongoing coagulation, we also have impaired synthesis of coagulation proteins and consumption of all of our clotting factors and platelets that occur, which can lead to a patient presenting with bleeding as well. So DIC can really present in more of a thrombotic way in some patients and more of a bleeding way in the other patients. And that is ultimately determined by the underlying etiology and the dominant pathophysiologic pathways that are present. So I've been saying these words, bleeding and clotting and consumption, but what actually is going on from a pathophysiologic perspective? So the first step in DIC is initiation of coagulation. And DIC is largely driven by our extrinsic pathway in our clotting cascade. which of course is going to require a tissue factor to start off the whole process and result in thrombin and fibrin generation. The tissue factor, as we know, is released in response to endothelial damage, but and of course this is always occurring in these patients with ongoing inflammation. But there's also some other inducers of tissue factor in patients with DIC. So the inflammatory mediators, cytokine, C-reactive protein, these molecules can also initiate tissue factor. So it really just contributes to even further initiation of coagulation and overwhelming deposition of fibrin. Now, in addition to the initiation of coagulation that's going on in DIC, we also have dysregulated anticoagulation. So all of our major physiologic anticoagulants become affected in DIC. We have reduced levels of antithrombin 3, and that's for a couple of reasons. We have impaired synthesis of proteins, we have ongoing coagulation that antithrombin is acting in, and it can also be degraded by enzymes that come from activated neutrophils. Our protein C system is also compromised because of impaired protein synthesis, and our tissue factor pathway inhibitor, this protein that typically regulates our extrinsic pathway and keeps all of our hemostasis in check, is just unable to regulate tissue factor activity sufficiently in DIC. And if all of that wasn't enough, our fibrinolytic system is also compromised in DIC. We do have some breakdown of fibrin that's occurring in these patients, but it's just not enough to keep up with the amount of fibrin that's actually getting deposited. Now, once again, of course, when it comes to diagnosis, we don't have any single laboratory marker that can really confirm a diagnosis of DIC. So the guidelines that are out there for management recommend utilizing a combination of lab parameters to make a diagnosis. There's a couple scoring systems available out there as well that largely refer to these lab values in terms of helping providers to diagnose DIC and predict clinical outcomes. So the first lab abnormality that we see, of course, is thrombocytopenia because of all of the consumption of platelets happening into our fibrin clots. We also see a prolonged PT-INR and a prolonged APTT, and that's because of the ongoing consumption that's occurring, impaired factor synthesis, and sometimes even loss due to the massive bleeding in patients that present in that fashion. We have decreased levels of fibrinogen, and again, that's because of the ongoing consumption that's occurring. All the fibrinogen that we have is being shunted over to form more fibrin. We have increased D-dimer levels, indicating, and D-dimer, of course, being a fibrin degradation product, showing that there is some breakdown of fibrin that's occurring, but again, not enough to keep up with the fibrin that's being deposited in DIC. And as we've already mentioned, we have decreased levels of antithrombin 3 and protein C. Which brings us to our next assessment question: which of the following lab values is typically going to be elevated in patients with DIC? Is it fibrinogen, platelets, antithrombin, or D-dimer? Yeah, D-dimer. Very good. So now coming back to our patient, patient CW, given the information that we have with a low 4T score, hematology is actually more concerned for something like septic shock or DIC as being the cause of his thrombocytopenia rather than HIT, and made a few recommendations. So the recommendations, of course, were to follow up on the HIT antibody that was already pending at the time of the consult, to start a low-dose bivalirudin infusion, because at this point we've started down this workup for heparin-induced thrombocytopenia, and we should be considering that there is a thrombus present until proven otherwise. And we'll talk about where the low dose comes in a minute. An ultrasound is recommended to evaluate a little bit more for thrombus, and fibrinogen and antithrombin were recommended to complete the DIC workup.
So thinking about management of heparin-induced thrombocytopenia, there's a Choosing Wisely campaign that was put together by American Board of Internal Medicine colleagues, and the intent of this was to promote conversations between provider and patients. This campaign's goal was to avoid wasteful or unnecessary medical tests and treatments and procedures. American Society of Hematology, as a part of this campaign, developed a list of 10 evidence-based recommendations. Number 9 on the list is don't test or treat for suspected HIT in patients with low pre-test probability of HIT. This was recommended because testing may lead to false positive results or misdiagnosis. An alternate anticoagulant is costly and can put the patient at risk for bleeding. Also, unnecessary cessation of heparin therapy can put the patient at risk for thrombosis. Based on these recommendations at UVA, we have come up with a risk stratification or a flow diagram of how to manage patients with suspected HIT. So what we recommend here is to first calculate a 4T score. If the low pretest probability is less than or equal to 3, this is where we would think that the HIT suspicion is HIT is unlikely, and we can actually resume heparin for our patient. However, if in 24 or 48 hours later, if the suspicion is still there and patient is placed in the intermediate or high probability or tested, or the 4T score initially was intermediate or high probability, this is where we would discontinue heparin and start an alternative anticoagulant. We also, at this time, is when we recommend testing for the platelet antibody testing that we would set. If this platelet antibody testing comes back negative with an optical density less than 0.3, as I showed you earlier, then HIT is unlikely and we can resume or restart heparin or continue heparin as we had for the patient before. But if the platelet antibody testing comes back positive with the optical density greater than 0.3, then SRA, sorry, there's a typo there, optical density greater than 0.3 for positive platelet antibody, then the SRA testing will automatically be sent to the lab. And if the SRA is negative, again, at this point, HIT would be unlikely and we can resume heparin. But if SRA is positive, this is where the suspicion of HIT now turns into a confirmed diagnosis, and we would think that HIT is likely. We can start DTI and also look into scanning the patient for a possible DVT if we haven't already done so. So if the suspicion is high and patient is confirmed with HIT, we would start considering the full management. The first step in this management would be stopping heparin therapy. If a patient was on warfarin prior to heparin infusion, prior to suspicion of HIT, we would want to reverse that warfarin. You would give either IV vitamin K or PO vitamin K. The reason why we're doing that is because we're avoiding the risk of limb gangrene that can develop in patients with HIT. After we have discontinued heparin, and just discontinuing heparin is not the only management for HIT because patients at hypercoagulable risk, so we need to start an alternative anticoagulant. This is where we have three options. We can either think about a direct thrombin inhibitor, and we have a list of three: lepirudin, argatroban, and bivalirudin. Lepirudin is no longer available or manufactured by the company, so that's not an option anymore. We can think about indirect 10A inhibitors. There's danaperoid, which was withdrawn from the market in 2002. It is only available in Canada at this point that I know of, and actually Canada uses this as their first-line agent for management of HIT. And the other agent we have is fondaparinux, and then the one other category we're going to talk about is direct oral anticoagulants. So on our formulary, we have argatroban, which has been FDA approved for prophylaxis and treatment of HIT. We have bivalirudin, which has not been FDA approved for the management of HIT, but many studies have investigated it. Fondaparinux, which is not approved for HIT, we use it as off-label, and there's been many case reports, so I'm going to discuss that a little bit. And direct oral anticoagulants have not been recommended by any of the guidelines for use of HIT, but I'm still going to discuss its use. So thinking about argatroban first. Argatroban is reversely binds to thrombin and inhibits fibrin formation. As I mentioned earlier, it has been FDA approved for patients with the treatment of HIT, and it's also been seen in patients with HIT requiring PCI. For treatment of HIT, we do not need to give a bolus of argatroban, and you can start a continuous infusion. We would use 2 microgram per kilogram per minute for all patients unless they have hepatic dysfunction, heart failure, post-cardiac surgery on anasarca, where we would dose reduce these patients. To monitor argatroban, we use APTT. Our UVA range is 60 to 90 seconds. While PTT is what widely is used, but when patients are going for procedures and argatroban is used at that time, we use a point-of-care test, which is ACT, and the ranges for that are a little different depending on where it's being used. One of the most important things to know about argatroban is that it significantly prolongs the PT-INR, so when we're transitioning patients to warfarin, it's quite a challenge. Its half-life is short, 40 to 50 minutes. It's hepatically cleared. There's no antidote available for this agent, and also 20% of the drug is dialyzable. So 2012 CHEST guidelines recommend using argatroban for all patients as first-line agent, but specifically for patients who have renal insufficiency and patients with renal replacement therapy. However, the guidelines do not point to the dosing of argatroban in renal replacement therapy and does not go into detail of what type of renal replacement therapy, which is where we read a lot of case reports to come up with guidance as to what to do with these agents and how to dose them in patients with CRRT, CVVHD, yep, and all that other type of renal replacement. Bivalirudin, the mechanism of action, it's a synthetic analog of hirudin and bivalent DTI that reversely binds to active thrombin and inhibits fibrin formation. As I mentioned earlier, it has not been FDA approved for treatment of HIT, but there has been evidence and case reports for its use. Specifically, bivalirudin has been looked at for patients with cardiac bypass surgery. And at UVA, the reason why you see a higher use of bivalirudin is it's actually have had many studies looked at comparing argatroban to bivalirudin, and we have seen that patients reach a therapeutic range faster and remain a therapeutic range longer compared to patients who are getting argatroban. We don't need to give a bolus dose of bivalirudin, just similar to argatroban. We can just do a continuous infusion. We do have to renally dose it and also dose it slightly lower for patients with CRRT. We adjust dosing of argatroban using APTT, similar to for bivalirudin, similar to argatroban, using APTT in the range of 60 to 90 seconds. We can again use ACT monitoring for patients with cardiac bypass or any other procedural testing where point-of-care testing is needed. It moderately elevates the PT-INR, and from our experience at UVA, when transitioning a patient to an oral agent such as warfarin, it's not as challenging as compared to argatroban is. It has renal clearance. It has a shorter half-life compared to argatroban 2, which is another reason why we use it more often. There is no antidote available for bivalirudin, but it is 25% dialyzable. 2012 CHEST guidelines recommend use of bivalirudin in patients with hepatic insufficiency and the ones requiring cardiac surgery. Fondaparinux, mechanism of action, synthetic pentasaccharide that causes AT3-mediated selective inhibition of factor Xa. It does not have any cross-reactivity with HIT antibodies, which is why we are seeing increasingly use of fondaparinux in patients with HIT. There was one prospective small study that showed similar rates of platelet recovery without new thrombosis compared to historical control DTI with fondaparinux, which has led to increased use of fondaparinux in our patients. However, there has been small increased risk of bleeding with fondaparinux use, and partly it's because it's renally dosed at UVA. While it's contraindicated in patients with creatinine clearance less than 30, we recommend for any patient creatinine clearance less than 40 not to use fondaparinux. It has a very long half-life, 17 to 20 hours, renally eliminated, as I mentioned earlier, so there's possible accumulation, putting patients at risk for bleed. There is no antidote available for this agent as well, and 20% of the drug is dialyzable. We can monitor anti-10A levels, but they're really not required for every patient, but only reserved for patients with obesity or renal dysfunction. Plasma exchange has been looked at for patients for the treatment of HIT. Really, it was looked at before the availability of DTIs. There was a retrospective study that looked at once plasma exchange was initiated 4 days of HIT diagnosis that the mortality was decreased. The way plasma exchange works in patients with HIT is that it decreases the anti-10A PF4, anti-PF4 heparin antibody titers. So this was shown to be effective, but really has not been recommended by CHEST guidelines to use in our patients. So we really reserve it as an option for patients who are DTI refractory to disease or have a high risk of bleeding where they can't get a DTI, so maybe we could consider plasma exchange. As you all know, plasma exchange is not benign. It requires lots of line placement and nephrology consults, so if a patient's at risk for bleeding, I don't really see us using plasma exchange for HIT management, but I just wanted you all to know that this is a possibility. Some of the limitations of current treatment options available with DTIs, we require continuous monitoring, continuous infusion, frequent dose adjustments. Some thought is that it decreases the thrombosis by 50 to 60%, but it doesn't reduce mortality. So we're putting patients on these agents where there's no mortality benefit. Patients are at increased risk of bleeding, so which is why it's important to really do the 4T score and only use it for patients where the 4T score is greater than 4. Also, there's no reversal agents for the DTIs. We have to, if a patient has a baseline elevated PTT, it makes it very difficult to manage these patients. And in the end, it becomes primary responsibility of nurses and pharmacists to watch closely for patients who are on DTIs and avoid any risk of bleeding. While indirect 10A inhibitors don't require continuous monitoring and continuous infusion administration, if a patient is to go home on fondaparinux, it increases costs for a patient out of pocket because most insurances are not covering fondaparinux anymore. Also, it's a subcutaneous injection, so patients have to give this to themselves for the duration of treatment. So both of these agent classes really put the patient at risk for prolonged hospital stay, especially if they're being transitioned to an oral anticoagulant such as warfarin or even staying on it as monotherapy. So I wanted to share with you a small retrospective study we did here at UVA where we looked at use of DOACs in patients with HIT. We looked at 11 patients who had positive SRA that were enrolled in this prospective analysis. All of them had positive SRA, but only 2 of them did not have clot present. We still included every single one of them in the analysis. These patients either got rivaroxaban or apixaban. Only 2 of these 11 patients had a bleed. One had hemoptysis and one had gastrointestinal bleeding. The patient that had hemoptysis also was diagnosed with lung cancer, advanced lung cancer, 2 months prior to diagnosis of HIT, so we think that played a role in the hemoptysis, and rivaroxaban was taken off for the patient. For the GI bleed patient, that patient was also on clopidogrel, was worked up for some cardiac disease as well, and had varices, which is what led to this bleed. So we don't know if it's really due to the DOACs. Out of the 11 patients, 9 patients were treated with DOACs successfully, but none of these patients that were, even with the ones with the bleed, developed a clot. This was further sent for publication, so you can see a better table that actually shows the platelet count as well. So the mean platelet count for the patients upon initiation of DOAC was between 50 to 150,000. So with patients with warfarin, when we transition them from DTI to warfarin, we wait till the platelets recover up to 150,000 before we do so. Whereas with our patients in DOAC, we have another advantage where we could possibly consider a lower platelet count and transition them so long as that they are stable and are doing better. So can we use DOACs in all our patients that are diagnosed with HIT? Well, some of the limitations that we have is that there are several case reports now and retrospective analysis supporting its use, along with the one that I showed you at UVA. There was one prospective trial that looked at rivaroxaban in the treatment of suspected or confirmed HIT, where rivaroxaban was given as the initial treatment, so DTI wasn't even given to these patients. This study was stopped early due to not being able to enroll enough patients, and 12 of these patients had a positive SRA and only 1 patient developed a clot. Since this study wasn't published or all the results weren't available, we can't really say we can use DOACs as acute treatment of HIT, but it's good to know that it's at least being looked at. The other limitation with DOACs is that we only have reversal agent available for dabigatran. We don't have a reversal agent for all the DOACs. While our study did show that platelet count between 50 to 150 was when DOACs were initiated in patients with HIT, I'm not sure if we know from the literature when to transition, at what platelet count to transition a patient to a DOAC with HIT. Also, the recent ISTH guidelines do not recommend the use of DOACs in patients greater than 120 kilos. So those are some of the limitations, but the advantage of using the DOACs in our HIT patients is that cost is generally not a barrier. Most insurances are now covering it or at least requiring a prior auth and getting the drug to our patients. They're easily administered, monitoring is not required. They have shown to be safe and effective in patients with DVT that were looked at compared to warfarin. So what would I recommend? Somebody who has an acute confirmed HIT, I would recommend still to use DTIs as the first line. Once the platelet count has recovered, patient is doing better and all the testing has resulted, at that point we can have a discussion with the patient as to what oral agent they would like. We can talk about warfarin, we can talk about DOACs, and see what is most convenient from insurance standpoint and patient's affordability standpoint to then consider DOACs. Especially DOACs are helpful in patients who have failed or refuse warfarin therapy, are difficult to monitor for INR, and have poor or diet or malnourished. Some of the other considerations with management of HIT that we need to think about is duration of treatment. CHEST guidelines recommend 3 months for patients with thrombosis of HIT because it's a provoking risk factor. HIT is, so we don't have to treat more than 3 months. For patients with isolated HIT, we can just do 4 weeks. For re-exposure of heparin, this comes up a lot. Somebody might have history of HIT, and they're now coming in for surgery, and we're often asked, should we use DTI? Should we think about heparin again? It's good to know that heparin antibodies are not detected, are undetectable levels from anywhere from 50 to 85 days post-diagnosis. So one approach we can take is that we could do an SRA prior to patient schedule for a surgery to see what that SRA looks like, and if it's negative, could we consider using heparin in those patients for that surgery? I know personally Winston and I were involved in a patient care who was coming for liver transplant and had a history of HIT, and we actually did an SRA in that patient. It was negative, but because the procedure was so long and such a high-risk procedure, we decided to actually give that patient bivalirudin during the transplant instead of using heparin. But there are different approaches to take, but it's important to know that heparin antibodies can be undetectable, and we can think about doing an SRA. Similarly, for short-term use of heparin for cardiac surgeries, that has been discussed in literature that we can use heparin, especially if the HIT diagnosis was more than 3 months ago. But if somebody's going for PCI, which is a high-risk surgery, we may not want to do that and may consider an alternative anticoagulant than heparin. One other thing I wanted to mention is this Avoiding Heparin campaign that was looked at one center in Canada, where they, after 2006, removed all of their unfractionated heparin in their order sets and everything with low molecular weight heparin, and they measured their pre-intervention to post-intervention era, and they found that there was a decrease in amount of annual rate of suspected HIT, decrease in annual amount of patients with positive HIT, and hospital-related expenditures decrease. So what can we do here at UVA? We can think about the patients that are on unfractionated heparin. Can we think about if they're not having any more procedures, can we switch them to a low molecular weight heparin? Can we switch them to an oral agent? Because the risk of HIT really begins between 5 to 10 days. So if they've been on heparin for 3 days and they no longer need it, can we switch them? Can we switch our patients from unfractionated heparin prophylactic dose to a low molecular weight heparin because the incidence of HIT is lower with low molecular weight heparin patients? And also, whenever a 4T score has been calculated and HIT is suspected, we should consider recalculating that 4T score to make sure we find the same score. So it brings us to the third assessment question. A resident calls you regarding a post-cardiac surgery patient in whom he's suspecting HIT since the platelet count declined by 50% on post-op day 2. He calculated the 4T score to be 4, and he is concerned that the patient will clot. He wants to send the HIT testing panel and start an alternative anticoagulant. He asks you for your help. What will you tell him? Show him how to place an order for HIT testing and bivalirudin and EPIC. Order apixaban 5 mg BID instead, since we routinely use them in patients with acute HIT. Calculate a 4T score again and proceed further testing and management of HIT if score is greater than 3. Steve?
Well, I think Steve.
Thank you for being honest. I appreciate that. I think so. I hope after this seminar, we will all take the initiative to calculate the 4T score and confirm before we decide to switch our patients to DTIs.
Okay, so I just wanted to end with a couple clinical pearls, I guess, in terms of managing thrombocytopenia related to either sepsis or DIC. So for our sepsis-associated thrombocytopenia, successful management of the underlying disease process and underlying sepsis is largely what's going to lead to normalization of platelet counts. And I think that some of that has to do with there being a lack of any one dominant clinical pathway as far as what's actually causing the thrombocytopenia and sepsis. We used to think that activated protein C, or Zigris, had a role in treating patients with sepsis and thrombocytopenia, but of course that was withdrawn from the market a few years ago because of the lacking of any significant clinical benefits. So I think when it comes to thrombocytopenia and sepsis, instead of looking at the platelet count as necessarily something we need to fix and address, we should really be using it more of a marker of disease severity, so as an indicator of how sick our patient is for other reasons and how aggressively we should treat their underlying septic episode, while also being mindful of potential bleeding risk. There are some agents that are potentially on the horizon for addressing sepsis-associated thrombocytopenia, though. The first one of these is Interleukin 11. So IL-11 is a platelet growth factor that is actually FDA labeled to prevent chemotherapy-induced thrombocytopenia, but that has also shown a significant mortality benefit in a small single-center study that looked at giving IL-11 to septic patients with thrombocytopenia. Recombinant thrombopoietin, or N-plate, is also another agent that is used for thrombocytopenia secondary to other reasons like ITP. But once again, a small initial study has shown, or suggested at least, a mortality benefit when given to septic patients with a low platelet count. And lastly, antiplatelet drugs are currently being investigated in both preventing sepsis and also in reducing organ dysfunction associated with sepsis that could potentially be related to these thrombocytopenic mechanisms. But these trials are still ongoing, so I don't have any information as far as outcomes at this point. Managing DIC and the thrombocytopenia that comes with it, again, is kind of similar in that adequate management of patients with DIC largely depends on managing the underlying clinical disorder. There are a couple of supportive treatment options that we can consider, but it has to be considered on a patient-specific basis depending on the clinical presentation. Is it more of a bleeding type or a clotting type, and what the underlying etiology is. So transfusions can be considered, transfusions of platelets and other blood products if the patients are presenting with more of a bleeding type of DIC. Prophylactic anticoagulation is actually considered to be the standard of care in patients with DIC, just given their high risk of VTE events based on the pathophysiology of the condition. The guidelines recommend continuing prophylactic anticoagulation, almost regardless of what the platelet count is, just because of the high risk of VTE events. But our clinical practice at UVA is to use a threshold platelet count of 50, at least to initiate conversations with our primary team in terms of risk-benefit of continuing this prophylactic anticoagulation, because the risk of bleeding is higher when the platelet count is below 50. And low-dose therapeutic anticoagulation can also be considered, especially if there is a confirmed thromboembolism or if the clinical picture is really dominated by this microvascular thrombotic state. The low dose comes in because the patients, as we talked about, are at risk for bleeding, so this is some of the rationale behind why the low-dose bivalent infusion was recommended for our patient. There are some experimental studies that suggest that in addition to potentiating antithrombin, heparin can also act through other mechanisms to potentially stop some of the activation of coagulation that's happening in DIC, but that hasn't really translated into anything clinically in any of the trials that have been looked at. There was a small study of patients with severe sepsis in DIC that showed a mortality benefit, although non-significant, but a small mortality benefit in patients that continued to receive prophylactic heparin compared with those in which the prophylactic heparin was held. So I think, if anything, that just kind of underscores the importance of continuing our prophylactic anticoagulation in these patients despite the abnormal coagulation parameters that we're going to see in those labs. So I wish I had some good concrete recommendations for you as far as how to treat patients with DIC, but I think the choice and dosing of anticoagulants really needs to be a patient-specific decision depending on how the patient's presenting and what is ultimately causing the DIC to happen. So now, finishing up and closing with our patient, CW, we get a little bit more data here. And we see that he has an elevated APTT and a low antithrombin, which are kind of suggestive of a DIC picture. But we also see an elevated fibrinogen, and that really points away from DIC. We also see on the ultrasound that he does have an occlusive thrombus in one of his upper extremities. So being that DIC is less likely based on these labs, now we're still left with either a septic shock or a HIT that we haven't completely ruled out yet. We're still waiting on those labs to come back as being the cause of his thrombocytopenia. So what do you guys think? Is it going to be sepsis or is it going to be HIT? So it's not HIT. The next piece of data we get is the heparin-induced platelet antibody assay, which is, of course, negative with a very low optical density, as we see here. We also see a platelet count that is starting to trend back up. So remember, the patient went to the OR, obtained source control of his infection. We started antibiotics, so we started treating this underlying septic episode, and you can see his platelet count started to trend up and recover from that point on. So it really supports the theory of sepsis as being the primary cause for his thrombocytopenia. So being that this patient did have a new occlusive thrombus provoked clot, he was transitioned to a heparin drip after these labs came back for the remainder of the admission, and ultimately discharged on apixaban for his thrombus. So now our last assessment question. Given the likelihood of sepsis-associated thrombocytopenia as being what's going on with our patient, which of the following agents might be something that's considered as an option in the future for treatment of this kind of thrombocytopenia? Interleukin 11, erythropoietin, warfarin, or interleukin 2? Ready? I think I heard an A. Yep, interleukin 11. And so just to end with a couple take-home points here, I think as pharmacists, drug-induced thrombocytopenia should be on the forefront of our minds in any patient with thrombocytopenia, but at the same time, we have to recognize how often heparin-induced thrombocytopenia is over-tested for and over-treated. And again, this is not a benign workup to commence, and there are consequences associated with switching up anticoagulation and going down this HIT workup pathway. So I think we can have a really good role in our teams with both helping our colleagues to calculate an appropriate 4T score and potentially steering our colleagues away from drug-induced causes when they're really unlikely so that we can avoid some of this workup. We can recommend appropriate lab tests, fibrinogen, D-dimer, AT3, things that might help us support these other causes of thrombocytopenia in our patients. And when it comes down to implementing anticoagulation in thrombocytopenic patients, regardless if this is HIT, if it's sepsis, if it's DIC, I think we always need to weigh the risks and benefits, whether it be prophylactic or therapeutic anticoagulation, and of course not be afraid to reach out to our hematology colleagues for help and advice, especially in some of these complicated cases like we saw in our patient in our presentation today. So with that, I think we would be happy to take any questions.